pregnant women with sickle cell disease are at increased risk of both mortality and morbidity in excess of what you would otherwise expect. And so here at ASH 2016, an interesting look at one way to dramatically improve outcomes, and it is a prospective implementation of a multidisciplinary obstetric team, and it really decreases mortality. So we're talking about a study that was done in Ghana, and I'm with Dr. Eugenia Vicky Asare, who is an MD from the Ghana Institute of Clinical Genetics and the Department of Hematology at the Teaching Hospital of Accra there. In a low and middle income country, this is an important issue, is it not?
Yes, it is. Because a meta-analysis that was conducted by our team from 2000 to 2014, published in the British Journal of Obstetrics and Gynecology, Buffo et al., it showed that pregnant women with sickle cell disease in both high and low income countries had an 11-fold increase in risk of death as compared to non-sickle cell disease pregnant women.
Yeah, that's pretty impressive. And I looked at the figures and I thought it was like a little over tenfold. So you're saying it's 11-fold higher in women.
10.9.
Wow. Describe the multidisciplinary approach that you're taking here, which I thought was fascinating.
So the leader of our team, who is Dr. Samuel Opon, he's an obstetrician, consultant obstetrician at the teaching hospital, recognized that this group of pregnant women had a peculiar problem. And sickle cell disease itself comes with both acute and chronic complications. And pregnancy is emerging as a life-threatening complication in this group of patients, or group of people, I should say. He set up a sickle cell clinic, antenatal clinic, from 2011, and within the first 3 years of the clinic, pregnancy mortality within this group of population was between 12 and 15%. So recognizing that there was a problem, he set up a multidisciplinary team, which included both local and foreign experts. It included obstetricians, hematologists, anesthetists with expertise in pulmonology. We had a pediatrician, and then we had nurses and midwives as well.
So you were able to compare that you had like a pre-intervention period.
Yes.
The pregnant women were admitted to multiple wards throughout the hospital.
Yes, they were.
Post-intervention, though, pregnant women were primarily admitted to 2 designated wards.
Yes.
For coordinated care.
Yes.
Now, maternal mortality did not quite reach that of women without sickle cell disease, but it really was reduced.
Yes, it was.
By about 90%, something
Yes.
like that. That's
Yes.
pretty impressive.
Yes, that is, yes. So what we did was we instituted simple protocols, okay, to prevent and manage acute chest syndrome. In the past, before this multidisciplinary approach, we realized that most of the patients, about 60% of the patients, died from cardiopulmonary complications, and acute chest syndrome was the major event. So one consultant would say, if you had an acute chest syndrome and you were pregnant with sickle cell disease, there was no returning back.
Right.
So recognizing this need, the simple protocols that we put in place was, one of them was to use latest balloons, okay, as incentive spirometry. Because incentive spirometry in itself is expensive if you look at a low middle income country.
Balloons, on the other hand.
Yes, balloons on the other hand, you can get it. It's quite cheap, okay. So it's the same principle that we used as the incentive spirometer. You use it every 2 hours during when you awake, during acute pain episodes,
right,
and after cesarean delivery. And then we started monitoring their oxygen saturation level as well. This wasn't done in the past. So by monitoring this oxygen saturation, we laid down criteria, or which I should say we adjudicated every case of acute chest syndrome. So as part of the adjudication criteria, we had reduction in oxygen saturation as one of them. So the pulse oximetry came in handy as well. And then since we were collaborating with the anesthetists, or what you would call intensivists here,
right,
we could transfer these patients to the ICU. Immediately they needed care. That wasn't done in the past. Transfer to ICU was quite problematic, so we ended up having to manage the patients in the ward. And then because the obstetricians had a passion for sickle cell disease, there were 2 of them, they managed to get the patients admitted on 2 wards. In the past, it was just all over.
Wherever, yes.
Wherever there was space available. But now that their care is more coordinated, they are on 2 wards. So everything is in place for us to manage them.
Now, you're at a teaching hospital, obviously. How difficult will it be for other centers to employ the kind of multidisciplinary approach that you studied here?
Okay, so I guess in a center that has a hematologist in place, okay, it's going to be quite easy. You should have an interest, a passion,
Right.
dedication.
That helps.
Yes, and then you really have to have it in mind that you want to help these patients. You want to reduce maternal mortality, because together everybody achieves more. That's teamwork. If you don't work as a team, it's not going to happen. In centers that do not have hematologists, what we could do was we're coming up with a manuscript. It's been submitted to Blood this year, so you could see how we went about it, the simple protocols that we did, and you could also try to replicate that, because it's cost effective. There was no cost added. There was no added cost.
Wow.
No other expensive technology was used in the management of these patients. So I guess it's going to be easy to replicate it if.
Wow. I mean, team-based care is very popular in the United States right now, but we don't see anything as dramatic as what you have seen in Ghana. So first off, congratulations.
Thank you.
And second, is there any other thing you want to target after this? This is a kind of success.
Yes.
What do you want to follow this up with?
Yes. So this was just done at one site. So the future, we want to roll it out to 3 major health facilities in Accra. Together, these health facilities cater for about 200 pregnant women with sickle cell disease. And then you also want to maintain that low mortality rate that we've achieved at the center. And then also I would want to look at adverse perinatal outcome in pregnant women with sickle cell disease, since this is the same if you compare it in both high income and low income countries. Then also we would want a comprehensive health center.
Yes, yes. Well, like I said, congratulations.
Thank
It was
you.
a very, very good study. And for the rest of coverage from ASH 2016, please see us here online as well as in print at ASH Clinical News. I'm Rick McGuire.